August 3rd, 2021. We're getting ready to perform a Deuk Laser Disc Repair on the neck, which is the cervical spine. This patient has 3 herniated discs in the spine, C4-5, C5-6, C6-7, and he's having neck pain, headaches, as well as right arm numbness and tingling and intermittent pain. So I'm going to go in and repair the 3 herniated discs. All right, our patient is asleep and he is laying on his the back of his neck. So just give me a few minutes to get started here, shot. Okay, so 2, 3, 4, 5, 6, 7. I'm at 6, 7. I want to be a little bit higher to start with. He has quite a big Adam's apple. Okay. Shot. 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 Let's get an AP. Quick AP. It's a quickie. Okay, lateral. Quick lateral. AP. Shot first. AP. It's a quick AP. Okay, looks good. Lateral. Come on, Jordan. You gotta be faster. Okay. Coker. We're gonna do it. You're pulsing, right? Let's do a lateral. AP. 2, 3, 4, 5, 6. Luis, you agree? It's perfect. You can see the spinous process is in the middle, and we're just at the middle where we entered the disc, so that's really good. Let's go back to a lateral view, please. So at this point, I'm happy with my AP or front back view. And the way we navigate for this procedure is with an X-ray machine in the operating room called the fluoro machine. And that's what I'm doing right now. The fluoro machine is a mobile X-ray machine that has the ability to take pictures and develop them digitally instantaneously. All right, once again, 2, 3, 4, 5, 6. I've got 5, 6. All right, let's get our discogram done. Now the discogram I'm going to do is going to show me the interior architecture of the disc, and what I'm looking for are tears in the back of the disc, and I'm wanting to stain the nucleus material. Shot. All right, there's a tear back there and a herniation. You can sort of see it. I want to advance this a little bit and try again. Shot. Okay, and I'm going to do another. Let me see, hold on. All right, shot. That's a good one. So that's a good one. The dye is leaking out, and the dye is leaking out of the disc through tears. So normally when you do a injection of dye into the disc called a discogram, the dye will stay. It looks like you're a bit overexposed. The dye will stay inside the disc in the nucleus, in the core, right where the tip of that needle is, and it'll form what's called a cotton ball appearance. So it'll be contained in a little ball, and this dye is not being contained. It's leaking out. It's leaking out through tears on the front, back, and sides of the disc. So this disc has been traumatized, and it's not the tears on the side or the front that are causing our patient's symptoms. it's always the tear in the back of the disc, 100% of the time, that causes neck pain or headaches from the neck or arm symptoms. Tears on the side and front never cause symptoms. I never treat them. In 16 years of doing endoscopic surgery, I've never treated them. And all of my patients have their pain go away, okay? So treating the posterior tear is what matters. Now, if you follow the tip of the needle backwards towards the spinal canal, you can actually see the dye going around. Now, do we determine that the arrow can be, huh? Oh, so you can, and they can see that. Oh my gosh, look at that. Yeah, perfect. So look at that curve right there where the arrow is. And put the arrow a little bit lower or something, or more to the right, just so they can see. Now you see that black line? It looks like a lump. Okay. I was going to say something else, but yeah. Anyway, that lumpy thing going backwards is the herniation. So that's pretty cool. And you can see the herniation. It's going to be in the back of the disc, pointing to the nerves and spinal cord. All right, at this point, I'm going to remove my needle. And the name of this procedure, if you're wondering, is called the Deuk Laser Disc Repair. It's a new, unique type of surgery. It's only done at Duke Spine currently. It's a type of endoscopic surgery, endoscopic spine surgery, and it's done using a single tube in the neck. There's epi, right? Yeah. So we're going to use a single 4mm tube to do the surgery. And we're going to fix all 3 discs with that tube. Okay. So we've got our guide wire in. I am going to remove actually I could make the incision first. It might be easier this way. And I'm going to make a small incision. It's 4mm. And that's why I mentioned the 4mm. How's the blood pressure? Good. Okay. So the whole surgery is done with a tiny little cut on the neck. And usually I can do 3 discs with 1 cut. That's 4mm, okay? I don't know that I'll be able to do that today because he has a really big Adam's apple or cartilage, and it may require me to make a separate incision. Jordan? So at this point, I have made the incision. Blood pressure is good. Patient stable. This patient is asleep. They're intubated. They're in general anesthesia. We have a no signal issue here, Sonny. Okay.
I lost the flow feed, Dr. Deuk.
Yeah, I know.
Oh, now it's back.
We know, but we're trying to find out why. So I may need Sonny here to help out. You got it back. Okay, good. All right, thank you. What was the issue? Unplugged the power source and plugged it back in. Would you let Sonny know, Diego?
Yeah, I hear him.
Oh, okay. I don't know if we need a new transformer or whatever this thing is.
Sure.
All right. So right now I'm bringing the dilator, which looks like a skinny little pencil, down onto the spine. And I'm going along the guide wire, which makes it very safe. And I'm pushing up against the front of the disc right now. Sean? So I'm ready to go into that disc. I want to check one more AP view, which is anterior, posterior, front, back. And I really, when I enter the front of the disc, I want to be in the middle as much as possible. Now, you don't have to be perfectly in the middle. There's 2 muscles that run along the front of the spine called the longus colli muscle. Now, look at that. You see the tip of the dilator is perfectly in the center of the spine, which is where, like, the ideal position normally. And then the guide wire goes off to the patient's right towards his foramen. And that's where we want to go with this dilator. But I'm not gonna, I'm gonna use I've used the guide wire to get the dilator down to the disc, lateral. Now I'm gonna enter the disc, and I'm gonna use my hand to gently push, just gently, okay? And once I'm inside the disc, I can get rid of this guide wire. Sean? The key is to get into the disc safely by using the guide wire. Once you're in the disc, you remove the guide wire, and then you can tap your dilator down. And what I'm doing is I'm spreading the jelly of the disc. Sean? So I'm not damaging the disc right now because the center of the disc is full of jelly. And just like you can't damage the jelly of a donut if you stuck something in it, you can't really damage the jelly of a disc, okay? It's avascular, has no blood supply, no innervation. Sean? I'm heading for that herniation because right where that herniation is, at the base of it, is where the tear is. All right? So there's going to be an annular tear here, and that's the tear of the annulus fibrosus. If you don't know what I'm talking about, check out our video at Deuk Spine Institute channel on YouTube. Our YouTube channel has a new video that Zach just created. Zach and I created. And basically, that video shows how a herniated disc forms. It starts with a traumatic injury to the annulus fibrosus, causing a tear in the wall from inside to outside, and then through a series of loading of the disc, you put pressure on the core, the jelly, which pushes the jelly out through the tear. Then you get a herniated disc from that. Look at that. The dilator has moved back. I have to re-advance it. Sean? So that's just from intradiscal pressure. Sean? That's perfect. All right. And we'll get the tube down. I'm almost docked on the front of the disc with the tube. Sean? Yep. All right, now we're at the front of the disc. So I'm going to advance the tubular dilator through the disc. Hold that. It's getting stuck on here. Look at that. I've never seen it get stuck like that. That's interesting. It appears to be unobstructed, but maybe some there we go. There's no tissue or anything, which is good, right? Yeah. Sean? All right, so I'm going to bring this tubular retractor down, but I got to watch the tip of my dilator and make sure my dilator doesn't keep going in, because if my dilator keeps going in, I could end up in the spinal cord, and we don't want to be in the spinal cord. That's how you get a complication. Sean? But obviously the dilator slipped back a little bit. I'm going to have to move that forward again in just a minute. But it's just little taps, little advances. Actually, the two of them are moving together now, which is kind of good. Sean? Sean? All right. Pretty close to where we need to be. Sean? Yeah, that's good. So, you can see on the X-ray lateral view that I am at the back of this disc, right where the herniation is, okay? And I'm going to zap this herniation out. I'm going to clean up the annular tear. It's called the annular debridement, and that was pioneered by myself, Dr. Deuk Majan, here at Deuk Spine Institute about 16 years ago. We first published it in 2012, just about 10 years ago. And that was published in Surgical Neurology International. It's a free, open access journal, medical journal about spine neurosurgery procedures, such as this one. I am a neurosurgeon. So the nice thing about it, I published in that journal because it's prestigious, but also because I wanted everyone to have access to this, you know, for free. I didn't want people to have to pay to read the articles that we published. All right, so can you guys see here what we've done?
Yes, sir.
It's pretty beautiful. Patient's face is here. He's looking up at the ceiling. His chest is here. His neck is here. We're on the left side of the neck. And I always go and enter the neck on the opposite side of the worst arm symptoms. So if a patient has bad right arm symptoms, radiculopathy on the right side, I go on the left side. If he has radiculopathy more on the left side, I go on the right side of the neck. And he's got a giant Adam's apple here. And he's also got a tube in his mouth. He's intubated, he's asleep, he's safe, his airway's protected, he's deep asleep, he's under general anesthesia, and he's gotten muscle relaxer. This is very different than the Koreans who, you know, have done this in the past, this type of surgery, not the same as what I do, because they don't do an annular debridement. And if they do now, they've copied me. So I'm the first in the world to do an annular debridement endoscopically and publish it. And we call that the Deuk Laser Disc Repair. That's what separates this procedure from all other spine surgeries. All right, we're going down the hole, and down here you can see little bits and fragments of disc. I'm going to improve the focus a little bit for you. Beautiful.
I have no feed of the endo.
What?
I have no feed of the endoscope.
Be careful with that back table, okay? All right, well, we can't wait for you guys to have a view of the endoscope. We're going to get started. You're at 20? Whoa, whoa, whoa. Where's Zane? Why? His what? Why didn't you tell me? Luis. I don't care if it's at 1 o'clock in the morning. I need to know. Anything that affects my procedure, I need to know. You understand?
I understand.
All right. So this is the herniation down here in little bits and pieces. The blue thing with the glass pipe is the laser. Who, he called you or texted you?
He texted me and he said he's gonna text Sharon Foley at the same time.
All right. Understood.
I already talked to Jordan yesterday in order to run the machine.
No, that's fine, but I need to know.
I didn't plan to use it today, honestly.
To what?
To use him today. I didn't plan to use it. Yeah.
I know, but just let me know.
Yeah.
I like to be aware of things.
Yes, sir.
All right. So anyway, for those of you who just tuned in, you're watching a live surgery today on August 3rd, 2021. Our patient traveled from where? This piece of herniation here? These are all pieces of the herniation, by the way. Where did this patient travel from? Anybody know?
Is this Louisiana?
He's not Louisiana.
No, it's I think it's Texas, no? Is coming from Texas? Texas, yeah.
From Texas. Okay. Our patient is from Texas. And once again, he has 3 herniated discs in his neck. And we are going to be repairing all 3 with the Deuk Laser Disc Repair endoscopic procedure. And in Texas, all they do is basically fusion. So he didn't want fusions. He didn't want an ACDF, anterior cervical discectomy and fusion. He wanted to do something that was less invasive and didn't involve metal and fusing. So he learned about the Deuk Laser Disc Repair. And these are all pieces of herniation, by the way. They're all being released and floating up through our little tube. Now what I'm working on here is actually the herniation itself and the annular tear together. We're a little bit overexposed. There's another piece of herniation. It's beautiful because I really just went and tapped right into the back of the herniation with this laser. It's better, yeah. But look at all the fragments of herniation there are. It's not like one piece, you know. It rarely comes out as one piece. There's another piece right there, a big one. It's just multiple chunks. And in this particular disc, this is the 5-6 disc, there's just a lot of chunks. So everybody's herniation is slightly different, but I would say 95% of the herniations I've operated on, they all come out as chunks, like this. That piece right there has been heavily collagenized. Again, I'm just floating them out. floating him out the tube. You got to be careful because your tube can actually move. The end of it can pull back or forward. So you have to just make sure you use the reference of the end plates. That's the end plates right there. And just look at all these chunks in here that are here, you know, from the damage to his disc. So he must have had a pretty significant injury to have all this damage back here.
He told me that was military active.
Military.
Yeah.
So something in the military. Thank you, Luis. Oh, it's unfortunate. So, once again, this is the C5-6 disc herniation that we're dealing with. And look at all the little pieces of herniation here at the back of the disc. These pieces have torn through the annulus and have lodged themselves in the epidural space. That's what you can see on the discogram as well. And they're rubbing up against the spinal cord and the nerves. And this herniated nuclear material is very inflammatory to the body. So what it does is it actually causes inflammation to happen in the back of the disc here, right where the annular tear and herniations are. And it's that inflammation that actually causes all the pain, the neck pain, the headaches that people get when they get the cervicogenic headache. All right. That's the foramen. There's a piece of herniation sitting there. And it's just stuck down. It's just stuck down in there. So we're going to work on it. This is a bone spur I'm working on right now. There's a piece of herniation right there. Yeah, this surgery is not possible without the laser. We get people asking me all the time, do you have to use a laser? The answer is yes, you have to do it right. So the laser is not a gimmick, it's the real deal. And without the laser, you're not going to get anywhere near the results that I have with my surgeries. We're getting at about 100% elimination of pain almost every single surgery. Our average these days is 99% elimination of neck pain or back pain, thoracic pain. And there's a reason why. Luis, why is the laser so special?
Why the laser? Because it's more precise. It's
More precise. Yep. Can regular surgical instruments remove all this stuff? No. So they're all scarred down. Can regular surgical instruments remove these bone spurs we're taking away so easily? No. That would be very difficult to do. It takes drilling with a drill if you do an ACDF. Okay? So we're doing it without a drill. This is all stuff in the foramen, inflammation on the right side. So I got to get back to the other side because you can see there's just the whole disc has been damaged from left to right. It's not just one side. This is kind of in the middle of the disc here. And all this is herniation as well. So I got to turn my scope around to face me and come towards me. I'm standing on the patient's left. So I'm going to have to start working the opposite way now and head towards his left. Now, yeah, he doesn't have left arm symptoms, but he has neck pain and headaches. So that's what this central area does. It causes the neck pain and headaches and balance issues. So, yeah, the foraminal component pinches the nerve and causes radicular symptoms down the arm. But the central component of the herniation and annular tear causes neck pain, cervicogenic headaches, and could cause myelopathic symptoms like balance problems or urinary problems. So If you just treat the foraminal component of the herniation with the laser endoscopic Deuk Laser Disc Repair, you're only going to get rid of the arm symptoms, but you won't get rid of the rest, the headaches and neck pain. You have to treat the whole thing, unfortunately, to get rid of all the symptoms. So I'm going to the opposite side. A lot of scar tissue here. A lot. This is all scarred up posterior longitudinal ligament. I've already gotten most of the herniated fragments out. You can see some of them are still stuck down. And that tube that I'm working through is our metal tube that you saw earlier. All right? And it's quite literally 4 millimeters from side to side. You all see that? At the end of the tube, it's not even 4 millimeters. The outside is 4 millimeters. The inside diameter is about 3.6 millimeters. Or 3.4 millimeters. I can't remember which it is, but the inside diameter of the tube is about 3.5 millimeters. The outside is around 4 millimeters. So this whole surgery is being done with a 4 millimeter incision. There's very few people in the world that know how to do anterior cervical endoscopic surgery. And as in probably 5 in the whole world. And of the anterior cervical endoscopic surgery, I am the pioneer of the Deuk Laser Disc Repair, which is different than everyone else's because what's the problem? Because we're debriding the annular tear. If you don't clean up the annular tear, you're not going to get rid of the neck pain, the headaches, and even the arm pain. Everyone thinks of disc herniations as being pressure on a nerve. That's not really what's going on. It's actually inflammation on the nerves. If you want to learn more about it, hey, can you show our video, Sonny, to the audience, the new video that was just published on YouTube, or put a link up?
Yeah, I was gonna play it as a commercial
play
break.
It. Yeah. Yeah. Play it now. Play it now for them. And also add a link to it in our dialog box for YouTube and for Facebook.
No problem.
And Periscope.
Okay.
All right, so this is right on top of the spinal cord right there. Okay, that is not the spinal cord, but there's a thin layer of inflamed ligament sitting on top of the spinal cord right here. I am not going to go to the spinal cord level. That would be stupid, because then you can damage the spinal cord. So I'm like a millimeter or half a millimeter above the spinal cord, and that's where I'm going to stay. Here's that foramen. Now that I've worked the other side, you can actually get a better appreciation of the foramen. On the right side at C5-6, and there is some thickened ligament from inflammation in the foramen. I'm trying to get rid of this little guy. And I want to thank Jordan for doing double time today and filling in on fluoro and laser. The good thing is we don't use both at the same time, so it is humanly possible. Or should I say superhumanly possible. Ooh, that's right on the nerve. It's incredible. Look at that. I just zapped all that away with the laser. You can't do this with any other tool. That's out the foramen. So the foramen, the marginal, lateral marginal line of the spinal cord is right around here, and all that is neuroforamen from there to there. And you can see the uncinate process. And you can see I've gotten rid of all that herniation and thickened ligament in the foramen. It's gone. So that's his right foramen. That's the main reason he came. That and the neck pain. All the herniation's gone. Let's look across one more time to the other side. Oop. I have the laser set so that it pushes in if we get any resistance. All right, it's looking really good. I'm pretty happy with that. A little bit of annulus there, a little scar tissue, in the annulus. So what's going to happen then after the surgery is all this area will seal off with the natural disc, the annulus, the part that used to be there, that we were born with. The annulus fibrosus is made from collagen, and this will heal with collagen. So, you know, it's quite interesting, but there aren't many tissues in the human body that heal with the same thing that they're made from. Like, you know, basically scar tissue is collagen. So your skin has a scar. It can kind of heal, laser off, with collagen, which is in scar tissue, but it's missing the elastin. But the annulus fibrosis is all, do we want to do the betadine?
Yes, sir.
The annulus fibrosis is all collagen. Huh. Oh, let's use that. It's the same one, right? Same needle? Yeah. And we're going to use it for the others. I like it. We're just doing a little irrigation. Huh? Yeah, and then we'll switch. Wait, I need to clear it first. Okay. Well, I want to use regular irrigation.
Regular irrigation?
Yeah. Yeah. Saline?
That's how it goes.
Yeah, we need some saline because I want to clear this out, right? All right. Yeah, just hand it to me when you're ready. Hand it to me when you're ready. So we've completed our Deuk Laser Disc Repair with one of the discs, the middle one. That's the number 5-6. And now we're going to take this tube out and go for the next disc. So take a look here at the incision. You can see the whole thing. Can you guys see that okay?
Yes, sir.
So this is the collarbone, and this is the neck, and this is the face with the chin right here. He's looking up. This is his left side. You can see all the pieces of herniated disc here. Luis, I'm going to put these right here, okay? On your table. So you have some samples. But all those pieces of herniated disc that I got out, we didn't really collect them. They just kind of floated out right here.
Perfect. Thank you very much.
Okay? And you can see I've got the tube in here still, and I'm going to take it out, but I'm going to have to take it out in such a way as to, all right, you can come in, as to be able to move to the next disc without coming out all the way. So I need to slide along the front of the spine, which is the anterior longitudinal ligament, to get to the next disc. And typically I go south to the bottom disc, and then I make my way back up north to the top disc later. Blood pressure's good, you're happy? All right. Do we have any questions from our audience? Let's go north.
None
a
at the
little bit.
moment.
Huh?
None at the moment.
Okay. For those of you watching on, so you need an orbit change. You see the back of the bones is kind of offset. He's just a little bit, like 1 degree. So you're watching a live surgery on August 3rd, 2021. This is spine surgery, and it's at the Deuk Spine Institute where we broadcast all of our surgeries live. We've been doing so for 9 years since we opened our doors here at the Surgery Center of Viera. We use a combination of eye in the sky, third person, along with fluoroscopic views. It looks like we're still rotated a little bit. Head straight up and down. Doctor? Okay, shot. That's fine. I'm going to go down to the next disc. Shot.
Dr. Deuk, we have a question.
Sure.
Any surgeons in Pittsburgh, Pennsylvania you have trained?
I couldn't hear what you said.
Oh, sorry. Any surgeons in Pittsburgh, Pennsylvania you have trained?
There's no surgeons in Pittsburgh or anywhere in the United States that I have trained. It's unfortunate, but the reality is that most spine surgeons are in love with implants, metal, fusions, artificial discs. There's a love affair between spine surgeons and spinal implants. And that's been going on now for about 30 years, maybe longer. The reason is simple. In the old days, before metal implants came along, all spine surgeons had was laminectomy, microdiscectomy, basically surgeries done without metal implants. And they weren't very effective surgeries, and they caused instability. That's where we are? No? So over time, spine surgeons learned, including myself, that when you combine a decompression, which is like a laminectomy, microdiscectomy, with a fusion, you actually get better results. Come on, Jordan. You got to pay attention to what I'm doing. And so spine surgery evolved, Sean, to doing fusions. And by the way, it worked really well. But then along came endoscopic spine surgery. I need an AP view. And endoscopic surgery like this was created by the Koreans primarily, the South Koreans. And they were the pioneers, along with Dr. Banati and Dr. Parvis Kambin in Pittsburgh. Dr. Kambin is from Pittsburgh, but he's retired, and he's one of the first endoscopic spine surgeons in the United States for lumbar spine, but not cervical or thoracic. So Kambin was really the true first pioneer in the United States. He was in Pittsburgh, and he no longer practices. Shot. All right. Shot. 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 AP. But Dr. Kambin was the first to do lumbar, lower back, for lumbar discs. I got to move it to the middle. You're AP there, right?
Doc, you have another question.
Just give me a second. I need to focus right now. Is that true AP? Perfect. Lateral quickly. Sorry, I can't take a question this second. Give me a mallet. Shot. Shot. All right, give me an AP. So you got to use two fluoro views. So you hear me calling out to my technician, Jordan, AP lateral, AP lateral. And what he's doing is going back and forth between a side view and a front view. That looks pretty damn good. Let's go back to a lateral. So I'm in the middle of the spine. It's a little bit rotated, but we're in the middle of the spine, which is good. And now I'm at the disc at C6-7, which is the one below I just fixed, right at the entrance of the disc. And I'm going to bring this tool to the back of the disc. Okay? And I can feel it sliding along the disc, the plane of the disc. Okay? That's good. Take it. Let me see it. Shot. Pipe cleaner. So now that I've moved the dilator, which by the way is only about 3.2 millimeters wide, I've moved that into the disc. Shot. Is that me? Shot. 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 All right, so I'm trying to clean the disc material that's got stuck in the tube. Shot. Trying to clean it out. Okay, which I just did. And then I'm going to do my discogram, because I still want my discogram. Shot. Perfect. You can see there's some leakage in the front around the tube, and there's some leakage in the back where the tear is. Okay. Now, yeah, I have to advance it now all the way back. Shot. Shot. So I'm getting to the back of that disc, right where that tear is. Shot. Little baby steps. Okay, I don't want any kind of craziness happening. If this tube goes in too far, this metal dilator goes in too far, it will paralyze the patient. So this is why the Koreans stopped doing these types of surgeries. They actually had too many paralyzed patients. They'll never tell you that, but that's what happened. And they didn't do what I do. They do it very different. They used side-firing lasers. They used patients awake, moving around during surgery, which I think is nuts. But anyway, they're the ones who taught me the basics of cervical endoscopic surgery, such as access of the disc, discogram, and placement of the instruments. These instruments we use here at Deuk Spine Institute for this Deuk Laser Disc Repair, they're all FDA approved. Nothing is experimental. It's all been peer-reviewed and published more than once to be safe and effective. So the surgery you're watching is the most advanced spine surgery in the world for herniated discs. And in the neck, it's really the only surgery that cures neck pain, headaches, and arm symptoms like arm pain, numbness, tingling, and weakness. All right, so now I've got my dilator tip at the back of the disc where the tear starts and the herniation starts. I'm going to bring down this tube through the disc. Once again, we're not damaging the nucleus pulposus of the disc. We're just passing through it. Shot? So the nucleus jelly in the middle of the disc is totally inert. It's a lot like Jello. Sup? And it doesn't have nerves. It doesn't have a blood supply. It's like this, just this jelly. And you can't really hurt the jelly at all. So I'm passing through the jelly to get to the back of the disc where the annular tear is. Sonny, did you find that video, the YouTube video?
I did. I linked it.
Oh, did you show it?
Not yet. You were showing your endoscope view.
Why don't you start showing it?
Okay.
So Sonny's going to run a video, and while I do this and get in position, which you guys have seen already, and in that video, Sonny's going to show you. You're still relaxed, right? Because this disc is just giving me a fit. It's like it's just got a lot of resistance to get back there. And it could just be that it's very scarred up, which is likely. But I want to make sure it's not because he's compressing the disc.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen.
Show you the stages of how a herniated disc forms
Inflammation from the annular
and
tear can
how
spread
it
to
becomes
nearby nerve
painful.
roots,
And this
causing
is the
back pain.
first time in the world that it's ever been explained to the public. And the reason is because the
Signals travel
surgeons
up
and
nerves
doctors
to the
around the
brain,
world don't
causing
even know
localized back pain.
this scenario. This is discovered at Deuk Spine Institute. We call it the pathophysiology.
Pain signals reach the primary
Pathophysiology
somatosensory
means
cortex, causing
how
conscious
a
awareness of pain.
disease is created and how a disease affects a human. Are they able to hear me, Sonny?
Yeah, and it just finished.
All right, so what you saw on the video was that the tear forms in the back of the disc, in the annulus, through trauma, some type of trauma, car accident, whiplash. And then, after the disc is torn in the back, you lift something or you get some kind of a force on your spine that pushes on the jelly in the middle of the disc, and that pushes the jelly out through the tear. Once the jelly pushes out through the tear, we call that a herniation. And then it creates inflammation inside the tear where there is a blood supply. And that causes the neck pain, the headaches, and the arm symptoms, is the inflammation. So it's not the pressure of the herniation on the nerve root like everybody thinks. It's actually the inflammation from the annular tear that spreads onto the nerve root, causing the arm symptoms. Spreads onto the dura around the spinal cord that goes up around the brain. That causes the headaches that people get when they have a herniated disc. That's painful. So, and then of course the inflammation inside the annular tear itself is what causes the actual neck pain. So neck pain, headaches, and arm symptoms are all explained through inflammation, all occurring within the annular tear and spreading. Okay. Watch that video a few more times if you want. That's why we posted it, so you guys can sit there and study it and learn about the truth. Unfortunately, 99.999% of doctors in the world don't know this yet. It's literally was just released. So nobody has made that discovery but us. And we decided to make a video to explain it to people. All right. Once again, we're doing our laser disc repair. We're now at the C6-7 disc. Look at all this scar tissue and calcification of the scar tissue called dystrophic calcification. I'm trying to move this tube, okay? Take a look at, turn the light on for a second. Sonny, go to the eye in the sky.
We're there.
All right, I'm trying to move the tube. Okay, if you look at the bottom, the tube's not moving. Okay, go back to the endoscopic view. There's no movement of this tube at the bottom of the disc. Why? Because the disc is so scarred from chronic inflammation from the annular tear that it's not, the bones aren't even moving. Now watch what happens at the end of this surgery. At the end of this disc repair, I'm going to be able to move these bones again. And so I'm actually restoring movement to the disc. So Deuk Laser Disc Repair that you're watching is the only surgery in the world that can actually give people back movement to their discs that are damaged. There's no other surgery. Now an artificial disc they say it preserves movement, which means it doesn't take the movement away. But it really does. If you read the papers and understand, artificial discs actually fuse over time. And then you lose that movement completely. But the Deuk Laser Disc Repair, I'm actually removing all the scar tissue back here that's holding the bones together, keeping them from moving. So people actually gain movement after the surgery. Now, we've never studied kinematics of the spine to prove it, but you can see it in every one of the surgeries I do. And, you know, I'm kind of over the publishing stuff because, to be honest with you, these journals are really controlled by, honestly, a group of, for lack of a better word, the good old boys club. And I'm not a member of that club. I'm kind of the outcast black sheep. So, you know, getting them to publish my work is very difficult to do because they're so biased. And honestly, I really don't care. I'm not trying to impress them. I really want to just get people understanding what's going on and seeing the benefits of this procedure over anything else. All right, do you have another question?
Yes, doctor.
Huh?
Yes, doctor. The question is, which company scope do you use?
So your voice is, you have to speak a little bit clearer. I apologize.
Yeah.
But can you enunciate the words a little bit better, Diego?
Yes. Which company scope do you use?
Which company scope do I use?
Yes.
Great question. I use a Wolf, W-O-L-F, Wolf endoscope. It's made in Germany. It's the best in the world, in my opinion, for spine. I've had other endoscopy companies trying to get me to use their scopes, but nope. The Wolf endoscopic system is the best. It's all FDA approved, and unfortunately, the reality is that it's very hard to learn how to do this surgery safely, and so most spine doctors have no clue that it even exists, and unfortunately, they're stuck doing fusions, which, by the way, I was doing fusions 26 years ago, and I still do them to this day, but fusions is an older technology. And the problem is that still that's what's being taught in all the training programs in the schools, basically, to all the surgeons, is fusion. So they don't know any better. And the reason they're being taught is because their teachers are on the payroll for the companies that sell the screws and rods. If you go and look at these spine meetings and look at who's giving all the talks, it's all given by surgeons that are being paid off basically by these spine companies that manufacture screws, rods, cages. So Unfortunately, it's a cycle that I can't fix that's going to continue to go on. By the way, these are bone spurs I'm removing. This cycle of bias towards expensive implants and fusion surgery is something I cannot fix myself. I can only make the public aware of it. But the doctors being trained, they actually make really good money doing spinal fusions. More than I make doing laser surgery. More than they will make doing laser surgery. So, endoscopic surgery. So unfortunately, we have a whole industry of spine surgery that's biased towards fusions and artificial discs because their education is compromised at the level of the university by their faculty who are being paid off, usually as consultants or advisors, quite a bit of money. You've probably seen it in the news, that to the tune of millions, sometimes hundreds of millions of dollars. And so I consider myself an independent because I'm actually here and doing medicine not for myself or the money, but for the patients, and I do what's best for the patients. I'll be honest with you, I actually enjoy doing these surgeries more than fusions. I make less money than a fusion, quite a bit, but I don't care. I'm not here for the money. I've already made money. So I'm going to do what's best for people. And if I had this problem, I want this surgery. I want an endoscopic Deuk Laser Disc Repair. I don't want a fusion, you know? And I have people come from all over the world because they feel the same way about it. The only reason anybody would get a fusion is because they don't know about this surgery, that it exists, or they can't afford to pay their deductible or copay or co-insurance to get it done. But my goal is to make it so that this surgery is available and affordable to everybody, so they don't need to have fusions. This surgery will literally eliminate spinal fusion someday when enough doctors are trained to do it and they have the equipment and they actually get paid for it, because that is a problem right now. Because you have to fight, many of the insurance companies have to be fought to get paid. So that's the reality. You know, I don't control that side. The people do. The patients do. If you're prepared to fight for what's best for you, then by all means do so and get the best surgery available. Or settle for a fusion because that's what the doctor wants to do, because that's where they make their most money. All right. There are cases where I cannot do laser surgery. They're rare, but there are cases. I just had one in clinic, as a matter of fact, a patient who wanted laser, the Deuk Laser Disc Repair, and they have a spine that is so bad, I just cannot do the laser surgery. It won't work. I mean, I can do it, but it's not going to work. So I don't believe in doing things that I know ahead of time aren't going to work. Look at the movement of the bones, by the way, now. Look at them, left and right. They're moving. There's a herniation right there. So I got to flip this around to get it. So we've actually improved the movement. It's not much, it's a few degrees, but then again, the discs themselves don't move very much in the neck. Only like 2 to 3 degrees normally. So if I give them 1 or 2 degrees, I've actually restored some of the movement back to their disc. So think about it. If normally you can move 3 degrees in the disc, and I've given them back 1 degree or 2 degrees, then I've given them back more than they came with. And there is no surgery in the world that does that except for this surgery. So artificial discs are motion preserving supposedly, but Deuk Laser Disc Repair is motion restoring. See the difference? Right, Luis? We restore motion. We don't just preserve it.
We have another question, doctor.
Yeah.
Lower back is... Oh.
I'm sorry?
Does having a previous ACDF surgery preclude you from having Deuk laser procedure for adjacent segment disease?
Oh, great question. So does having a previous anterior cervical discectomy infusion, ACDF, preclude you or prevent you from having this Deuk Laser Disc Repair done for what's called adjacent segment disease, which is a disc above or below the fusion that's worn out? The answer is no, it doesn't preclude you at all. However, to know for sure if I can treat an adjacent segment disease with the endoscopic Deuk Laser Disc Repair, I would need to see x-rays, because what I'm looking for is your metal plate, oh, look at those herniations, they just came out, of the neuroforamen on the right side. Beautiful. Look at how smooth they are. They've been worked on by inflammation, just smoothing the surface out over years. There's still another one in there. Sorry, I got a little carried away there. But the answer is I need to make sure the metal plate doesn't ride over and cover up access through the front to those adjacent discs. So I need an x-ray. I usually want a CAT scan too to make sure there's no osteophytes blocking access to the front of the disc. Okay? So the answer is usually having a prior ACDF doesn't prevent you from getting a Deuk Laser Disc Repair on your neck. What's that noise? Huh? I didn't hear. Fluid?
No, she's testing.
Oh. Okay, fine. Sorry. Anytime I hear something I'm not used to hearing, I get a little nervous. These are all pieces of herniation, by the way, just beautiful. Look how they're popping out of the epidural space, and I'm floating them out. Why are they not staining blue? Oh man, this is just stuck. Why are they not staining blue? They're not staining blue, even though they're, what? Yeah. They're not staining blue because they're collagenized. They're so scarred up. They're basically chunks of scar tissue now. So the hunks of disc herniation have been turned into hunks of scar tissue. All right, almost done at this level. Just got another 2 minutes here. So did I answer that question all the way? I can't remember if I did or didn't. Got a little distracted. I apologize.
We have another question.
Yeah, I'm sorry. So just to recapitulate, yes, you can do this endoscopic laser surgery adjacent to a prior fusion in your neck as long as the metal plate and bone spurs don't ride up and cover the access to the front of the disc. And of course, as long as the esophagus is mobilized, if you watched in the beginning, if you haven't, go back, but I actually have to push the esophagus away from the spine in the very beginning and get a clear access to the front of the disc, front of the disc. So if I can't do that because the esophagus is scarred up and sitting on your plate, just scarred there, and I've seen that before in real life, then we'd have to stop and not be able to do it. So I would say probably 75% of the time another herniation coming out. 75% of the time I can do it, 25% of the time I can't because of what are called anatomical constraints. Does that make sense? So it's not because you can't do it, it's because they may be blocked. The access may be blocked by the prior surgery's metal or bone spurs formed after the prior surgery or scar tissue scarring the esophagus down. All right. But I would say it's worth looking at. And for those of you who don't know, Deuk Spine Institute offers a free MRI review service, free video consultation, free MRI review to anyone in the world wanting it. You don't have to be an American. You don't have to be a Canadian. You can be anything and just somebody who wants answers. And we offer this for free. As a matter of fact, I'm the one who sits there and does these with Luis and my team. So I personally look at each MRI to decide if that person can be helped, which, 99% of the people we see can be helped. So send your MRI in, get a free consultation. There's no obligation to treat with us. There's no payment. It's all free. And we're the only people that really offer this kind of free service because we really want to help people understand what's going on and what can be done. All right, we're done here. Way done. It's amazing how far lateral we got. A little bit of grunge in there, but it's sitting right on the nerve. I can't risk damaging the nerve. So we're done here. Let me just, wait, yeah. Give me 1 second. All right, was there another question?
Hang on a second, Doc.
Diego? While Diego's looking, for those of you interested, Duke Spine Institute has an app. It's free to download. It doesn't cost anything, and it's full of useful information where you can get questions answered and learn about herniated discs and learn about pain, back pain, neck pain, and how to cure it. You can just go onto your Apple, or you can go onto your Android, and so we have an app for both, Apple and Android. Nice job. And basically, download the app, and you find we're going to be updating it soon and making it even more useful. So it's a really good spine app. It has a lot of good information. Plus, you can tap into live surgeries and ask questions. Like I said, you can learn more about facet treatments or disc treatments or sacroiliitis or any condition relating to back and neck pain. Also, we have a Facebook support group called the Spine Surgery Support Group, and basically that support group is, let me have this first, and then I'll take that back. The Spine Surgery Support Group is free. It's open to anyone who wants to be a member to learn more about spine conditions. We don't allow advertising in it. But we do allow honest, free discussion. We certainly don't allow trolls. But if you're interested, go to the Spine Surgery Support Group. Hold on a second. Here's some more disc material. Where do you want it? It's going to get stuck in there. Okay. All right. Any questions there, Diego? Okay, so I can't hear you, Diego, so I don't know if your mic's on. Anyway, we just did the C4-5 and, we did the C6-5-6 and 6-7. The disc we just completed was C6-7, and we've already done C5-6, the one above, so we got to go up 2 discs to do the last one. Okay, so far our patient's doing fantastic. We've lost about maybe 5 drops of blood the whole surgery so far, which is nothing. And he's doing great. He's stable, he's asleep. And when he wakes up, that pain that he had before surgery will be gone forever. And he will have some discomfort from the surgery itself. All right, let me just do this. All right, let me focus for a moment. We got some tubes and wires in the way. Let's get those out of the way. And I'm going to go ahead and take this out, and then taking my tube out. Shot? Yeah, good. So we're out of the disc, and I'm pulling it up. Take. All right, so we still have our dilator shot. That's it? No dilator shot, good. All right, so 2, 3, 4, 5, 6, 7. We just completed 6, 7. We've already done the one above that, and now I got to go all the way up 2 discs. So let's see if we can make this happen. It's not going to be easy because that Adam's apple cartilage is in the way. Shot? All right. You literally have to feel with your fingertips. Shot? Right on the edge there. Out. Shot? All right, now I got to make my way up north. Shot. AP. You got to make sure you stay in the middle of the spine as you do this. This is the hardest part of the entire surgery, is moving from one disc to the other. But it's doable. I've done this surgery now. Okay, I need a lateral view, but you can stay there for a moment. All right, just give me one more AP now. All right, too far to the side. Shot. Okay. Go lateral. Now notice when he doesn't have the fluoro set, I'm not moving, okay? I'm not moving. I only wait till I know I can follow what I'm doing on the fluoro. Shot. Good. I need an AP. So I actually had to move the cartilage over with my finger right there. I never had to do that. Shot. But I had to do it now. Okay, I'm off to the left side. Shot. All right. More centered. Shot. Let's go lateral. So I actually had to push his cartilage out of the way so I could move up and further north. That was pretty interesting. Like I said, never done that before. All right, so I need to get further north here. May have to move it a little more. Pop out, shot. Yeah, kind of went back into the hole I did before. Now I'm out, shot. Give me an AP. So I'm halfway up the next vertebral body. 2, 3, 4, 5. I'm at C5 on the lateral view, and I got to make sure I'm staying in the middle, which I'm off to the right just a little bit. Shot. That's better. Now lateral. So with that move, I went medial and north. Almost there. Just need a little more. Shot. Yeah, big bone spur. Shot. I can feel it. Shot. AP. Slipped. Hold on. AP. It's a quick AP. Not bad. Lateral. Take, hold. Just about done. Shot. Shot. All right. AP, Coker. Make sure we're in the middle. So it's just going back and forth with the fluoro, the x-ray, making sure I'm happy it's good. Lateral. Mallet. Now I can anchor. I'm right on the ALL, anterior longitudinal ligament. I'm in the middle of the spine. I'm right there at the next disc. Shot. Yes. AP. Again, I keep going back and forth with the x-ray machine. We're using a pulse mode, which means we're delivering much less radiation per view. That's perfect. Back to a lateral. We're in the middle on the front view. So I'm very happy with our navigation. We're using an x-ray machine to navigate through to the proper disc, proper location on the spine. And of course, what you can't see with the x-ray machine are the soft tissues, right? Like the carotid artery, the jugular vein, the internal jugular, basically, carotid artery. And of course, being up here around C4, that's where the carotid bifurcation is, pipe cleaner. So you're dealing with a lot of valuable, high real estate, high stake structures in the neck, which is why this is not a surgery you can just, watch a YouTube video on, Sean, or no offense to YouTube, our hosts, but Sean, but you can't, just watch a video on how to do it and expect to do it. You literally have to be trained, and I believe it's at least a year training to be able to do surgeries like this. I've been doing these surgeries now for 16 years, and I've done over 1,300 of them, and I've not had a complication. So we've been very fortunate with this surgery. It's very safe to do. All right, so really anyone can do the surgery. However, doing it properly to get the good results. Shot, it feels like it moved back a little bit. Oh my God, look at that. Yeah. So the disc is under so much pressure. Look at that. It pushed the tube back. Uh-huh. See that? That's pretty interesting, right? So why would a disc be under pressure? Anybody know? The answer is inflammation. What happens when you get inflammation? What happens when you get a thorn in your finger? Doesn't it swell? Yes, the swelling is edema from inflammation. What happens when you get a broken bone or broken arm? What happens? You get a swollen arm. The swelling is always from inflammation. Think about that. Inflammation. So this disc is inflamed from the herniation and the annular tear in the back. And that inflammation, Sean, causes this whole disc to swell. And it creates pressure inside the disc. Can you give me a little inline traction, please? Inline traction. All right, let's get a shot. Looking good. Shot. I want to move the tube in, but not the tip of the dilator. Dilator move back a millimeter. Let's move back another millimeter. So I'm going to have to re-advance the dilator. Shot. Just give me a second, doctor. Okay, back on. Back on. Go ahead. Almost done. Shot. Oh yeah, just about there. Shot. Shot. We're done. All right, we're done. So we're docked right inside the annular tear, and we're going to clean that annular tear up, and we're going to remove the herniations. Nice work, everybody. Perfect. We're done with the fluoro. So look at this. It's amazing. Three disc herniations. Let me have a marking pen.
I need a marking pen, please.
3 disc herniations. C4-5, C5-6, C6-7. It's sterile, right?
Yes.
All right, don't worry about it. You guys need to have this stuff here. All right? So, can you guys see here? Diego?
Yes.
One herniation was here at this level, another one here, and another one here. So we fixed 3 herniations with this tube by just directing it and sliding it along the spine with one 4mm incision. All right, we're going to be done in 10 minutes, 15 minutes. Doctor, if you want to start waking him up or getting him ready, switching to Tiva, whatever you want to do. All right, we're going to go ahead and get this scope in. Has the audience seen the tube, Diego? The tube that we do the surgery through?
Yes, they have.
Yeah. All right. Now, if we weren't using this tube doing endoscopic surgery, the incision for this would be about 6 inches on his neck. And patients that have ACDF fusions,
Lights off, please.
they don't just have big incisions, but they also have a lot of pain and trouble swallowing afterwards. Okay? And the trouble swallowing is because the swallowing tube has been manipulated during the surgery by the surgeon. Now this disc is very different. It's not like the last one. It's a more recent herniation. Look at all the blue, all the fluffy. Very different than the scarred up disc we just saw a few minutes ago. Right? The scarred up disc is all white, smooth, or chunky. And this disc herniation has lots of pieces again, but it's not as old, not as, not as influenced by inflammation as the last one. All right, so we'll get all these chunks out. There's a piece right there. Look at that big boulder of herniation. Pretty impressive. Let me try to grab it out. All right, so is our next patient here? Our next patient is a 1-level cervical. correct? We're doing one disc on the neck, and that should be a quickie. And then the one after, another one level. And then the one after that is a L4-5, bilateral, lumbar. The last patient today will be a lumbar endoscopic surgery, Deuk Laser Disc Repair, and he actually has had multiple spine surgeries in Louisiana and still in pain. And when I looked at his MRI, I could see why. He still had a herniation. So there's a lot of incompetent surgeons out there, folks, that don't do good work. And patients continue to have the same problem they had coming, going to the surgeon because the surgeon didn't do the treatment right. The other problem is the other surgeons don't know how to do transforaminal endoscopic surgery, so they do a laminectomy, which takes bone out of the back of the spine along with the ligaments in the back of the spine. So when you start taking bone and ligament out of the spine, it actually weakens the spine, destabilizes the spine. So the patients end up having more movement in a bad way that's unnatural. And so it's like taking a couple of walls out of your house and then a hurricane comes. What do you think is going to happen to the house? It's not going to last. It's going to basically fall down, right? It's going to blow away because you've lost that structural support. Well, the spine's no different. There's structural support in the spine that needs to be preserved. And when surgeons do microdiscectomy or laminectomy, they're taking the bones and ligaments out of the spine that normally support the spine and allow the spine to function without, what is that? They allow the spine to function normally without damaging itself. What? Yeah, irrigation. Thank you. I do the same thing. This is pretty badly damaged, you can see. A huge tear. This is the annulus right here, by the way. And we're debriding it. It's full of scar tissue and nucleus. All right, what other questions does our audience have for us? Look at the tear. You can see the torn edges.
Nothing yet.
Nothing. Okay. Well. Now this part has more collagen, more scar tissue. You can see it. And it's all calcified, so it's turning gold in color.
Oh, we do have a question.
Sure.
What is the difference between type 1 and type 2?
A little bit louder.
What is the difference between type 1 and type 2 collagens?
What is the difference between type 1 and type 2 collagen? Okay, great question. So there's actually more than 2 types of collagen. There's about at least 10, maybe more, like types of collagen. Collagen is a protein. And proteins are made up of amino acids, like building blocks called amino acids. And amino acids, there's about 21 different amino acids. And at least there were when I was in school. Maybe there's more now. But point is, the amino acids, imagine 21 little bricks, different colors, okay? Like little Legos that you can stick together, those Legos. So you have 21 of them, all different colors. Imagine the combinations that you can make. And so collagen and the different types of collagen differ in their primary amino acid sequence. Like any proteins that differ, they differ in the primary amino acid sequence. That's the sequence of amino acids that make up the protein. And again, there's 21 to select from. What determines the amino acid sequence? Genes, genetics. So genes are transcribed, and then they are translated into proteins. They're transcribed into what's called messenger RNA inside the nucleus of the cell, and then they are converted from messenger RNA, which is just a recipe, into a specific type of protein with a specific amino acid sequence based on the RNA sequence. So you have these different types of collagen that have different primary amino acid sequences. And amino acids are quite interesting. They have a very stable sequence of primary atoms. However, they have a side chain that differs. And the side chain on all these 21 different amino acids differs from its what it has in terms of the atoms. So if it's got nitrogen bound to it, or two nitrogens, or nitrogen and hydrogens, versus carbon versus sulfur. So the side chains are different atoms like sulfur, nitrogen, hydrogens, carbons, and oxygens. So depending on these 21 different side chains, that protein has a different biological activity. And what it does is the primary sequence determines the secondary sequence, which is your alpha helixes and beta pleated sheets, which are, structural shapes of the protein, which has a profound impact on its function. And then finally you have these tertiary and then quaternary structural possibilities. And tertiary means that protein can fold on itself in certain ways to create zones or areas that have specific biological functions by interacting with other molecules in the body or tissues. Okay? I don't mean to make this complicated, but what it means is that depending on the primary amino acid sequence, your protein can be similar to another one, but if it differs with just one amino acid, it has a completely different function. It works differently. It could still be collagen, but a different type of collagen. So there are many different types of collagen, and they all differ in their primary amino acid sequence. And because of that, they start getting some really interesting side chains, and because of that, they have different biological activity. So I don't know if that makes sense to you, but the primary sequence determines secondary and tertiary sequences, and then it could also associate with other proteins and form multiglobular molecules with multiple protein chains, and that would be your quaternary or fourth level of structure. So I hope that makes sense. So these different types of collagen really only differ in their amino acid sequences, and hence in their properties differ slightly based on that. Make sense? So just to go back to the Lego analogy, because Legos are typically straight, like if you stack bricks, they make a straight line, right? They just make a straight structure. But imagine bringing in bricks that are curved, bricks that are longer, shorter. So it's basically not the same brick anymore. Their bricks are different, and you can attach them. So that's what having different primary amino acid sequences allows the protein to do, is to have different types of Lego bricks that go in different directions and have different properties, like the ones with the wheels, the ones with the steering wheel, the one with the wheels, the one with the barrel or the scooper. So once Legos were no longer just monomorphic bricks, and they started having all these other geometrical patterns, that's what happens with different types of collagen, is that they have different shapes. They're still Lego, but they just have different shapes and therefore different functions, different properties. So anyway, that's the best explanation I can give you. All the collagens are all related in terms of they have a preserved base shape. However, what differs is some of their properties, because of the side chains, are different with different types of collagen. Okay? So there's not just type 1 and type 2. There's type 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and even 13 that I'm aware of. And there may be more than that. When I was in college, years ago, there were only like, I think, 3 types of collagen that they knew about, and now here we are, 30 years later almost, and there's a lot more that have been discovered. So, yep. Any other questions? We're done. I'm wrapping up.
That'll be all.
Huh?
That's all.
Well, go ahead and, if you have more questions, type them up, and I will be happy to answer them for you over there in the conference room when we do our, what do we call it? Where I come and talk to everybody face to face. We do our face-to-face Q&A. Okay? So go ahead and type up your questions, and I'll come answer them for you face to face. All right. Why don't you guys, let me show you this, and then you guys can cut to an infomercial. Infomercial. We have our own infomercials. How cool is that? All right. We use a little betadine here. Betadine is an antiseptic, and we used to use bacitracin, but then bacitracin became off the market because people were injecting it intramuscular, and it was having a toxic effect. So the FDA said, hey, no more intramuscular bacitration injections. And basically when they said that, everyone panicked and overreacted. As a result, they took bacitracin, which is a great antibiotic, off the market. And it's been impossible to find it. So we've had to find alternatives to the coverage of gram-positive bacteria. Now, a lot of doctors don't even use any antiseptic, except for the IV antibiotics we give all of our patients, which is Kefsol 2 grams IV, 1 hour, within 1 hour of skin incision. But I like to use a little bit in the irrigation as well, just as an extra precaution. Okay, so I'm going to hold pressure for just a minute. Let me show our audience real quick. Can you guys see this?
Yes.
Now we have 2 types of endoscopic retractors. Okay, this is a retractor. Why? Because it retracts the tissue around the tube. That's why it's called a retractor. It's a tubular, because it's in the shape of a tube, retractor. We have 2 types for our surgery. One is the small tubular retractor, and we call this the McDonald's coffee straw, because it's about as narrow as a McDonald's coffee straw. Okay, that's how tiny it is. 4 millimeter external diameter, tiny. And then we also have the bigger tubular retractor, which you'll see later today, which we call the McDonald's shake straw. Now, I don't want to get in trouble with McDonald's, but if you ever go to McDonald's and have coffee, they give you that little coffee straw. That's how big this tube is. If you ever go to McDonald's and have a shake, the shake straw is how big it is for the lower back when we do lumbar. So cervical is a coffee straw, and lumbar is a shake straw. Okay? Now, let's take a look at the incision. All 3 herniated discs were fixed with this 4 millimeter incision. Incredible. All right, so you're going to do the benzoin and the steri strips and a little Band-Aid.
Yes, sir. The bandage, want to show you if that's the correct one. I want to make sure.
That's fine. It's a little big for the neck. That's good for lumbar.
Okay.
Do we have a smaller one for the neck? All right. Where are the steri strips?
Yeah, it's just
All right, let me have the steri strips. So let me see the steri strips. Now there are smaller steri strips than that. I mean, they sell smaller ones. Like, yeah. You don't need a narrower steri strip.
So you want the same
Yeah.
shorter. Okay.
Yeah.
Gotcha.
So basically, look, you can probably do it with this right here.
And you only want 2.
Yeah, I mean, I don't know if they sell them less than that, so we don't be wasteful. But I would just take these, and you just need 2 side by side here, or 1 of the regular ones. But always put a little benzoin on top and bottom, not inside, but on top and bottom. Ooh. Oh, my heart just skipped a beat. You almost what? That's hilarious. All right, very good. So let me see. Are we done with pressure? You have a smaller Band-Aid? A regular one? Oh, but do you have one like here in the first aid kit or something? Do we have a smaller one? All right. So just get the benzoin going and just a little brush. And a little brush here. And you want to let it dry. Okay, that's the key, is let it dry.
Correct.
And this is what you do. Okay, just like that. And that actually helps it dry. And now you put your steri strips on. Okay? Thank you. Yeah, that Band-Aid's fine. And Louise, take a tiny little piece of the 4x4. No, let's just use that Band-Aid that she has. All right. Uh-huh. Look, Louise, you cut this and just fold it in thirds like that, and you put it on top of the steri strips and then put the Band-Aid across if you want, or even that's too thick, you can go half of that and cut it in half. Does that make sense? So you have a little pressure dressing as well. Let me get these steri strips on. Yeah, that's fine. But I like the whole Band-Aid. I like the whole Band-Aid idea. Band-Aid. It has to be literally, it looks like a Band-Aid, like that other one. So then you put that right there. You have that Band-Aid? All right, you got the rest? Yeah. I just think a regular Band-Aid is perfect for that. Okay, I'm heading over to answer questions. Great job, everybody, as usual. I'm going to call the EBL 1/2 mil. Thank you. It's not that that won't work. It's just... I know, but I really want the Band-Aid.
I understand. We'll find something.
So DLDR, left approach,
Traumatic injury to the disc can cause
C5,
annular
6,
tears to form.
6-7. Thank you, everybody. I'm going to go see her.
6-7. She does have a very short neck, so she might be interesting.
Pressure on the disc causes herniation of the nucleus pulpus
Wonderful.
through the annular tear.
Thank you.
Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel
live broadcast of a patient with 3 herniated discs in his neck. For those of you who don't know what a herniated disc is, if we look at this model here, the spine inside of our bodies is made up of bones that are stacked on top of each other called vertebrae. That's a vertebrae, that's a vertebrae, and it keeps going all the way down. Between vertebrae are joints that move, and the biggest joint is called the disc. This patient had herniated discs at C4-5. That's the 4-bone, 5-bone disc, the number 5 and 6 disc, the number 6 and 7 disc. So I repaired all 3 discs by going through a tiny little cut in the front of his neck that was 4 millimeters. I went into the disc, I went past the normal stuff, got to the back of the disc, and I used the laser in the back to remove the herniation and clean up the annular tear. We pioneered this technology here at Deuk Spine Institute, not the endoscopic anterior cervical approach, but the debridement of the annular tear and removal of the interposed nuclear material that is still a herniation, but it's a contained herniation. That's where the source of neck pain and headaches comes from. And then, of course, irritation of the nerve root right behind the herniation and annular tear causes the arm symptoms. And our patient had numbness and tingling in his right arm. So we went on the opposite side of the arm symptoms that were the worst, and we were able to remove the herniations. You could see during the video that there were a lot of chunks of herniation, and I got them all out using a laser and using irrigation flow. So the surgery went very well. We did it all with one tiny little incision. He'll be here for an hour, and then he's going to be discharged home. And he's here with his sister, and they've traveled from Texas to get this surgery done here at Deuk Spine Institute in Orlando. We broadcast all of our surgeries live every week. We have 4 surgeries today. The next surgery will be another cervical surgery on a patient with 1 disc herniation that we're fixing, and the approach is on the right side. So she's also having arm pain on both sides, and when I talked to her before, it was mostly the left arm that was the worst, so we're going to go on the opposite side of the neck, as we always do, but we'll be able to treat both foramen and get rid of the herniations on both sides. All right, do we have any questions from the audience? No, we do not. Thanks for watching, and we'll be back in about